Hi, everyone. It's a pleasure to be able to speak today at the HAI Research Day. My name is Elena, and I'm a first year master's candidate in the Health Research Methodology program here at McMaster University. Today, I'm going to be presenting about a living systematic review and network meta-analysis project on drug treatments for COVID-19. This is a project that started about a year ago and is led in large by investigators at McMaster. And I'm very honored to be speaking on the team's behalf today to present the work that we've done. So, as we've all been experiencing, the COVID-19 pandemic has had a very substantial impact with over 150 million global cases and over 3 million deaths. Variants of concern are continuing to rise, and the number of daily new cases continues to increase worldwide. One of the pressing issues that we've had to deal with this pandemic is to identify and administer effective treatments. But one of the challenges that clinicians, patients, guideline bodies, and government agencies have been facing is this challenge of interpreting the results from trials that are being published at an unprecedented rate. In addition to a pandemic, we're also going through an infodemic. And on top of this problem, we also have the media that sometimes propagates misinformation. We even have governments around the world that are also touting drugs that are not shown to be effective. And so it can be incredibly challenging in this climate to decipher what information is credible and what information should ultimately be guiding our decisions and policies with regards to management of COVID-19. And so we've identified this need. Evidence users require accessible, up-to-date, comprehensive, and trustworthy syntheses of evidence to inform their decisions and policies regarding treatment of COVID-19. And so this leads us to our project. We are conducting a living systematic review and network meta-analysis to compare the effects of drugs for treatment of COVID-19. A key word in our project is living. And this is particularly interesting in the context of COVID-19, where evidence is constantly changing. And with our living systematic review, we are constantly updating our evidence syntheses to reflect or to incorporate new up-to-date practice. We're also conducting a network meta-analysis, and a network meta-analysis differs from a traditional pairwise meta-analysis in that it allows us to draw conclusions about the comparative effectiveness of drugs that have not necessarily been tested head-to-head in clinical trials. So our team is a pretty large team, and it's subdivided into smaller teams that each conduct different stages of the project. We have a dedicated team that is dedicated to searching and screening the literature on a daily basis. And the databases that they look within for pertinent literature include the World Health Organization COVID-19 database, Epistemonikos, and as well as 6 Chinese databases. This team screens the literature and they identify studies that are eligible. And these studies include preprints, in-press, and peer-reviewed reports of RCTs. We also include unpublished data that is sent to us directly by clinical trialists. And we require that these studies randomize patients with suspected, probable, or confirmed COVID-19 to either drug treatments, placebo, or standard of care. Once an eligible study is identified, the study then gets sent to the data collection and study appraisal team. And this team works daily to abstract data on the following characteristics: so trial characteristics, participant characteristics, and any data that is related to any outcomes of interest. We also assess risk of bias using a modified version of the Cochrane Risk of Bias 2.0 tool. What we look for is whether the
Sorry, everyone. Is it just me or is Elena frozen?
I was about to say the same thing. Yes, she's frozen. So we'll have to pause for a second. Let me see if I can get hold of her. Elena, can you hear us?
Okay. So how about, yeah, it seems like she disconnected. Let's give her maybe 30 more seconds to see if she can get back on. If not, maybe we can move on to Omotola's presentation, and then Elena can pick it up from where she left off if she's able to come back.
Okay, yeah, just give her a minute.
Okay, so maybe Omotola, are you ready to go while we wait for Elena?
Yeah, sure. I'm ready to go. Let me see.
It seems like Elena's back. Elena, can you hear us?
Yes, I can. Sorry, my Wi-Fi dropped.
No worries.
Should I continue?
Sure. We were ready to wait for you longer, but if you're ready to continue, that's perfectly fine as well.
What part of my presentation did we drop off at?
We were on the data abstraction slide, and you were starting to talk about using the modified version of Cochrane risk of bias tool.
Okay, perfect. I'll go back then. So apologies for that. So once an eligible study is identified, we have a dedicated data collection and study appraisal team who abstracts data on these following characteristics and outcomes. This team also assesses risk of bias within the studies, looking at whether there was a true generation of whether the sequence generation was truly randomized, or truly generated in a randomized fashion, and whether there was concealed allocation. We also look for whether trialists and participants were blinded and whether there's any substantial differences in co-interventions between the arms. We also look for whether there might be any missing data that could lead to bias. We also look for detection bias and also if there's any selective reporting of outcomes. So once the data is abstracted and is assessed for risk of bias, we then send the data to our data analysis team. And this team performs a Bayesian network meta-analysis using the GemTech package of RStudio. Our team only network meta-analyzes treatments with at least 100 patients or 20 events. And we decided on this threshold to avoid highly implausible and extremely imprecise estimates. Once the data is analyzed, it then gets sent to a team that assesses the certainty of the evidence using the grade approach. So the grade approach considers evidence from randomized studies to be initially high certainty, but if there are issues concerning risk of bias, inconsistency, indirectness, imprecision, or publication bias, that would merit a potential downgrade in the certainty of the evidence. And since we're also conducting a network meta-analysis, we also look for whether there might be intransitivity in the network and whether there might be any incoherence between direct or indirect estimates. So after consideration of all of these factors, estimates can either have a certainty rating of high, moderate, low, or very low. So now I'm going to present the results that we have so far. These are the results that are published in our iteration of the drug treatment NMA that was published on the BMJ site as of April 6. So within that iteration, we identified 196 trials, including 76,700 or so patients. 113 of these trials were network meta-analyzed. And these are just some characteristics of the included trials. So the majority of the data comes from peer-reviewed reports, although a portion also comes from preprint data. And some of it is also unpublished data that is sent by clinical trialists. A large proportion of the trials are registered, and most of them are inpatient trials. And risk of bias is predominantly at high risk of bias for most of the studies. These are the interventions that have been included in our network for mortality so far. In total, there are 22 interventions apart from standard of care. And this is a summary of our findings. So to the left, we have all of the interventions, and we have the each column represents an outcome. The second row represents the baseline risk, and here we display the absolute risk difference for each intervention compared to standard of care for each outcome. The coloring is used to indicate the direction of effect compared to standard of care, and the shading is used to denote the certainty of the evidence. So just to highlight a couple of interventions, we can see that corticosteroids probably reduces mortality and probably reduces mechanical ventilation, probably increases ventilator-free days. Interleukin-6 inhibitors probably reduces need for mechanical ventilation. Its effect on duration of hospital stay is perhaps less certain. We recently conducted a more up-to-date analysis involving interleukin-6 inhibitor trials, and we found that there is a subgroup effect wherein interleukin-6 inhibitors are shown to be potentially more effective when used in combination with steroids. Some other interventions, for example, JAK inhibitors have been shown to probably reduce duration of ventilation, although its effect on mortality and duration of hospital stay and mechanical ventilation are less certain. So these results are also disseminated in the form of an interactive infographic that accompanies our manuscript. This infographic is quite nice in that it shows you the number of trials that are included in the current iteration of the NMA, and it allows you to filter the results per outcome. So right now we have it displayed to show the results for mortality, and it provides you with a lay summary of the results along with the trials and participants that are included in the network. It also allows you to filter based on the evidence that you want displayed, so low, moderate, or high certainty evidence. And if you would like to know what is about a specific intervention, you can click on one of the nodes. And if you click on one of the specific comparators, it will show you what is the relative risk, as well as the absolute risk difference per 1,000 patients, and also what is the grade certainty rating. So these results were used to inform a Living WHO guideline that is put out by the BMJ, the MAGIC group, and also the World Health Organization. And so far, this guideline group has made a strong recommendation in favor of corticosteroids in severe and critically ill patients. They've made a weak recommendation against the use of remdesivir, strong recommendation against the use of lopinavir, ritonavir, and hydroxychloroquine, and a recommendation against the use of ivermectin for its limited use, for the exception of its limited use in clinical trials. So in conclusion, we provide rigorous and rapid information on the comparative effectiveness of drug treatments for COVID-19. And the results from our Living NMA have informed guideline recommendations that have very quickly become a trusted reference point for clinicians and public healthcare practitioners. And our Living NMA provides a model for efficient and rigorous evidence synthesis in parallel generation of guideline recommendations that can be translated to other disease areas. And finally, I would just like to acknowledge the wonderful team that is behind all of this work. Thank you very much, and I welcome any questions.